Hello, today is December 1st, 2011. My name is Luke Bracke. I'm a resident here at the University of Alabama at Birmingham who has had the privilege of training under the physician next to me who we would like to interview for the Living Archives in Anesthesiology for the Woods Library-Museum. This is Dr. James Boyce.
Thank you, Luke. Well, I was born in Weston, Ontario, Canada, which is in the southern part of Ontario. And if I give a lecture here at UAB, I'll ask those present if they can determine by my accent that I'm not originally from the south, but I say that really I am, but it's southern Ontario, Canada. And growing up, the typical activity was hockey. That was our major sport. Of course, with long winters, that's perfect for that country. And I went to school. I was an average student, not excelling. In fact, I remember in high school, the guidance counselor brought me into the office and told me that I probably should not consider going to university, that a trade would be more suited to me. And I think all he did there was hit a nerve that spurred me on to prove him wrong. But I was blessed with good parents, hard workers. My dad was a milkman in the city of Toronto. I have one sister, and Mom was a stay-home, at-home mom, and I think we benefited from that as children. My grandfather lived with us as well, which I remember fond memories of having his presence in our family. And went to medical school at the University of Toronto. It was an accelerated 6-year program, so we went in after grade 13. We have grade 13. I don't know if they still do now, but when I was a high school student, we had a grade 13, and after that would go into college or university in various programs, and mine was an accelerated 6-year program in medicine, and I graduated at the age of 24, and my plans were to do general practice, be a GP somewhere, and hence took the residency or the internship out in Victoria, British Columbia to fulfill that goal. But the upbringing, the home life was all good. I've often said that I'm very thankful that I was blessed with mediocrity as a hockey player, because any kid growing up in that environment, if you're good, you're going to go to the limit, and the limit often is kind of a dead end for a lot of very talented hockey players, but not talented enough to make long-lasting careers at that. And after they're through, then there's not much they can do. So I'm glad that I didn't make it to a higher level that would have interfered with the goal of being a doctor.
Dr. Boyce, you're being a little bit humble in that you were a fairly accomplished hockey player. Can you talk about playing hockey a little bit? Well,
I was okay, but by the standards of the Bobby Orrs and Guy Lafleur and other players, I was very mediocre. But I did play with the university team, Varsity Blues, and we did have fun traveling in some of the winter tours. I remember one year we went to RPI, Boston College, and ended up in Ann Arbor, Michigan, playing the Wolverines. And at that time, they had a young man from Saskatchewan, Canada, by the name of Red Berenson, and he and his teammates clobbered us. They were fabulous players, and we toured or came back to Canada with the tails between our legs. I played 1 year in a semi-pro league on the West Coast, played with the Prince George Mohawks, but there again, that was nothing that really should be noted in terms of being a major achievement. That's the year that I broke my femur. Skiing, by the way, not playing hockey.
What lessons do you think you learned from athletics growing up? And
well, I think there's a good lesson in persevering. And like I say, for me to accomplish things as a hockey player, I had to work hard. I had to persevere. It didn't come naturally. And I think that was, at the time, I probably didn't recognize it as something that I was learning, but it was clear to me that if I was to make any achievement at all, I had to work hard and had to persevere and not accept initial failures as a time to quit. So that would probably be the major lesson I learned, and I think that applied to what I have done and am doing as an anesthesiologist.
Your parents, they had an interesting, I think, goals for you and stuff like that. Will you talk about that for a moment?
Well, my mom was a real sports fan, and my sister married a professional football player for the Toronto Argonauts, and that delighted her. And to match that delight, if I made the NHL, that would have been wonderful. My dad really didn't have that same driving desire, but as long as I was getting a good education, that was his major concern. But yeah, to be a professional hockey player, that was a strong desire in the family. Also in that family, there were strong musicians. I have a second cousin who's actually now deceased. His name was Ellis McClintock, and he was first trumpeter for the Toronto Symphony Orchestra. And of course that was part of their cultural drive for me to gain that quality, and I never was very good at that, though.
At what point do you feel like you first started to excel at school?
I was sort of in the middle of the pack in medical school, so that's not really by the standards of the class. I was a B-plus type student in medical school. And then when I did my internship, you know, I made the grade and did what I was supposed to do, and then did general practice for 5 years. What turned things around for me was I broke my femur and did not think I could be a general practitioner anymore. So that was the factor that drove me to pursuing anesthesiology as a career. And during that time, I think I was the best student that I have ever been, because I was enrolled in the master's program in pharmacology as well as being a resident in, which is a 4-year program at Queen's in Kingston, Ontario. And I remember the excitement of being able to study and learn things that drugs that I'd been using in my general practice. Now I had an opportunity to really want to learn and study them, and with this master's program in pharmacology. So, you know, it was easy to get an A because I was so driven and excited about learning. So that was, I think, the turning point for me academically.
When you were practicing general practice, you had the opportunity to actually deliver a lot of anesthetics, is my understanding.
Yes.
Can you talk about that and
right.
and what you were doing? And
well, this occurred in Prince George, British Columbia, which is 500 miles north of Vancouver. So it's way up there, the same latitude as Edmonton, Alberta. And when it gets cold in the wintertime, like 20, 30 below is common. Well, in Canada, we don't have CRNAs, so a lot of us as GPs did anesthesia. And the way I got started doing anesthetics as a GP was one of the I believe the surgeon said, "Jim, we're kind of short of people to do some anesthesia. Would you like to pick it up and maybe help?" And I thought, yeah, that sounds like fun. Can't be too hard, you know, and just sort of be there and do something. I'm not sure what they did. But we had one graduate anesthesiologist trained in England, and she said, "Well, come on with me for a couple of weeks," and I did, and then she says, "We'll start you on Monday after the 2-week training program, and we'll just give you the kids' tonsil list so that, you know, something simple that you could do." So that's how I got started, and, you know, to the old saying that ignorance is bliss. Well, I didn't know enough to be scared enough, but I soon learned, because there were some hairy moments. But that's where I learned to do anesthesia. And there were a lot of GPs who had lots of skills, lots of techniques that fascinated me, and it was fun to see their ability. And of course, it's in a practice like that in Prince George, it's the camaraderie and the support that you have and feel is wonderful, because when you get into a bit of trouble, you got people around to help you out. But that's where I really learned to do anesthetics. Well, then when I broke my femur and decided to do it full time, I was going into the training program with some clinical experience, so I had kind of a jump on things.
What do you think you took away from your early GP experience and brought into anesthesiology eventually?
Well, I think the biggest thing was that I'm first a doctor, and that concept that a patient and I as a doctor, I can get the halo effect of your first impressions, and then pursue what you feel is appropriate, not wasting time on things that are probably not essential. But just that sense that evaluating quickly a patient as a doctor, not just as a specialist in anesthesia. And so I felt that was a real value those years as being a GP. Now, I don't say that everybody has to do that, but for me it was great. I don't regret a minute of it, and the some of the wonderful experiences I had as a GP were valuable as well. But I think, just if you would sum it up in terms of the practice aspect of being an anesthesiologist, it was, I'm a doctor first, and then after that an anesthesiologist.
This was a time in your life too that I believe you were starting your family. Can you talk about that?
Well, my first son, Christopher, all my kids were born in Canada. Christopher, the first, was born in Thessalon, Ontario, which is my first job after internship, and this is back in Ontario. It was an outpost hospital where he was born, and I was the camp doctor for the Ontario Hydro that were building the series of dams on the Mississauga River. So he was just 3 or 4 months old when I left that, and we moved out to British Columbia. And my daughter, Emily, was born there in British Columbia. And then when I decided to go back and do anesthesia, we moved to Kingston, Ontario, Queen's University. And that's where my youngest son, Jacob, was born. So when I came south in '76, I brought along my 3 Canadian kids.
You also have an interesting story with early ties to Alabama and meeting your wife. Can you talk about that?
Well, sure. We met in Augusta, Georgia, and this was in the summer of 1965, and this was the summer just before my last year in medical school. And a classmate and me came down to Augusta, Georgia to take a job in the emergency department. And the reason we did that was I wanted to do something different. And my mom used to date the then dean, Walter Rice. He was the then dean of MCG. And so contacted him, and he set us up with the head of the ER. And I came down with Dan Catron, a classmate, and so we worked in the emergency department. Well, it just so happens that Linda, my wife, had just graduated from high school, and she was visiting her sister in Augusta, Georgia, who worked as a clerk in the emergency department, checking patients in. So Linda took a job with her doing that, so that's how we met. Well, we dated for 1 month, and then I went back to Canada, and we wrote letters and phoned for a year. I came down on the bus and brought the ring. She was living at that time in Elba, Alabama, which I now have learned is L.A., Lower Alabama, and took the ring down and then went back on the bus, and then she came up after graduation, after I finished my 4th year medical school, and we were married in Canada in 1966. So that was my first introduction to the South.
Your time as an anesthesiology resident is when I feel like you really started to excel academically and show an interest, and I believe you wanted to stay in academics. Is that correct? Yes,
yes I did. During this combined master's program in pharmacology and being a resident, I was able to do some research. And I had worked with a chromatograph and was able to isolate some of the agents. The main one we were using was Demerol and then lidocaine. And the 2 metabolites of lidocaine I could now separate with this gas chromatograph. And then I started doing some research, kinetic type research on animals, and published a couple of papers as a resident. One of them, Nick Green, was the editor-in-chief of anesthesiology at the time, and he was quite helpful getting this paper published, one of the ones that I was able to publish. And but when I finished, I wanted to stay on because I had a protocol with this kinetic model with the lidocaine, but there were no jobs. And looking back on it, I mean, if a resident publishes 2 papers while as a resident, I mean, that's pretty solid an indication that this is going to be a valuable academician. And it still is baffling to me, unless I thoroughly annoyed the chairman or somebody, that I didn't get a job. But anyway, I'm glad I didn't, looking at how things have turned out. So I left the program. I did get the gold medal, by the way, for that paper that I presented in Montreal. It was the time during the 1976 Olympics when they were held in Montreal. And I didn't have quite the fame of Nadia Comaneci, but I did in my own circles. It was well accepted.
Who were some of your mentors at that time?
Well, we had 2 or 3 of our faculty had just come back from UC San Francisco under the tutelage of blanking on his name now. He was here as a visiting professor, Severinghouse, John Severinghouse, and they were just full of enthusiasm for bringing some of the novel ideas they got at UC San Francisco. And so this was Stan Pytek and Fred Wright, the chairman, and Frank Cervenko, and these guys were terrific. So I look back on them as being wonderful mentors, and I think it was Stan Pytek that was the major person who was encouraging to me to establish this concept of the pillar way to learn. and that is where you take a topic and you go deep. You don't stop. You go and kind of pursue some of the history. And for me, the first one was bronchomotor tone, which I think is very appropriate in light of the fact that our chairman that's an area of his original research as well. But that's where I think that influence, those guys coming back from UC San Francisco, that it really got me cranked up.
So as fate would have it, and Alabama fortunate in this scenario, there was no academic positions available.
Right.
So you came to Alabama.
I came to Alabama, and you know, the other option was to stay in Canada and do private practice. And that just did not appeal to me. And I guess it's because I have the teacher gene, I saw that as not attractive. So the next best, interestingly enough, was going back to being a GP again. And that's what I did. I came back to Elba, and or to Elba, because I never really had lived there before. This was Linda's hometown. You see, we had lived in Canada 10 years now, and she was kind of anxious to get back to the South, and me recovering from a fractured femur. The winters were a burden because I couldn't ski, couldn't play hockey anymore. And the idea of coming to the warm climate was very attractive. So, and Elba needed a general practitioner. So I thought, hey, let's go. So we packed up, and I got my boards. I went ahead and got that finalized, and my Canadian fellowship in anesthesia. But there I am in Elba, board certified in anesthesiology, doing general practice again for about 4 or 5 years. I guess it was about 4 years.
I think, too, this is maybe what I'd call your first true experience or opportunity to really delve into that teaching that you had talked about with the medical students that would visit.
Yeah, we had from the University of South Alabama, and these were family practice residents. Or no, they were med students. They were med students during their family practice rotation. Well, they would come to Elba because I encouraged our administrator to get a trailer and hook it up close to the hospital. So these guys would come and they would spend a month with us. And the way we worked it was, now in Elba, I was on call most nights. But when somebody came to the emergency department, I'd get the call. I'd say to the student, well, you go and check the patient out, unless it was an emergency, of course, and then I'd go right in. But after they had checked the patient out, I'd go down and we'd go over the findings. And some of them who had to come to surgery, then I would bring them in the operating room, and that's where I was able to teach anesthesia to some of these students who were doing their general practice rotation. And actually some of them did go into anesthesia as a result of that. But that was a great teaching experience.
After Alba, so I think in 1983 is eventually when you came to UAB, is that correct?
1983, right. April the 1st, April Fool's Day.
And how did you learn of the job, and how did you initially start?
Well, I just saw it. I realized at the time in Elba, if I don't get on with being an anesthesiologist, I mean, I'm going to lose opportunities. So what I decided was, well, I'm going to check things out. Well, I saw in one of the journals that Ed Ernst was advertising for faculty. So I jumped in the car and drove up and knocked on the door and said, he said, well, what do you want? And I said, well, I thought I'd like to join the faculty or talk about it anyway. He said, well, what are you doing now? And I said, well, I'm a GP down in Elba. He said, well, you gotta do a residency. And I said, yeah, I've done that. Well, where did you do it? I said, well, I did it in Canada. Well, we only take board certified anesthesiologists here. And I said, well, I'm board certified. I got my boards, and I had my little ticket, showed him. And he said, "Oh, what are you doing in Elba?" And I said, "Well, that's where I wanted to be, but now I'm looking to come here." And he says, "Well, come on in, let's talk." So that's essentially how I started, and that was the beginning in '83.
And early on, a position doing primarily ENT cases had come available, and who were you working with at that time?
Well, the interesting thing was there was Kirit Patel was the anesthesiologist who had worked mainly with Buddy Hicks and other ENT surgeons, and but he left and went into private practice, so there was this void. And so Hamdi Erdemir, who was he was the division chief at that time, said, "Well, I'd like to see if you could work in here." And I said, "Yeah, that's fine. I don't know anything about it, but I'm sure I could learn." Well, it was 2 CRNAs really that got me started, and taught me the nuts and bolts of how things were happening in the ENT module. And so I got started there, and then once I got a handle on the usual and customary way of doing things, then it started to grow, and I could expand a little on ideas, and that's how we started developing some of the techniques.
Speaking of techniques, in an example of your innovation, can you talk about the transtracheal jet ventilation?
Yeah, that was one example that came out of that early experience. At the time, the thoracic surgeon who did the transplants, lung transplants, was George Zorn. And he would like to have the patients not anesthetized, not under general anesthesia, but just blocked up so that he could do the endoscopy and check the anastomoses and see if everything was intact. So what we would do for these patients, give them some sedation, and then we would do glossopharyngeal nerve blocks, superior laryngeal nerve blocks. And then another technique was to take a catheter, 2% lidocaine on a syringe, and just insert it through the cricothyroid membrane, and aspirate it and pull the needle out, leave the catheter in place, and reconnect, and have the patient take a deep breath, inject the lidocaine, and they would cough, and the lidocaine would come up and anesthetize the upper airway. And after I did that several times, it seemed obvious to me, this is no big deal, sticking a needle through the cricothyroid membrane, and gosh, if you've got it in here, that would be an excellent way to administer oxygen in a crisis situation. So it was from that early experience that we thought, well, if we had a patient who perchance had supraglottic pathology that could totally obstruct during the efforts to secure an airway or administer an anesthetic or both, wouldn't it be better to preemptively put this catheter in place so that we would have our rescue already in place should that occur? That just made sense to me. And so that's what we started doing. And it was interesting here because after I had done maybe 10 or 20 of these, we had Meyer Rosenthal from UC San Francisco again visiting us as a visiting professor. And he was going around and he was looking at what's going on in the ORs, and I was about to do one of these procedures. So we got the patient set up, and I saw where he was and said, "Mike, come on over and I want to show you something that we're doing. The technique that we're using seems to work pretty good." So I did the technique, and we put the catheter in, the vessel dilator, and jetted oxygen, put the patient off to sleep, and then we were able to secure the airway. And he looked at me and he said, have you published this? Thought hadn't occurred to me. I thought, no. He says, I'll give you 1 month, and if it's not in for publication, I'm stealing it. I said, "Oh, that must mean it's pretty good." So I got on, I got things together, and we published that in I think it was, gosh, can't remember, 89 maybe, and it was in the Canadian Journal of Anesthesia. So it was, Glenn Peters was very supportive of that, and actually the ENT surgeons were too, as a technique.
The jet ventilation also you started incorporating eventually with transnasal jet ventilation. Can you talk about the benefits of that?
Yeah, I think that is really a significant contribution, particularly in the realm of teaching. Because here, what it allows a resident to do a fiber optic intubation on a patient without the anxiety, of causing any pain or discomfort or morbidity to the patient. And it gives them the advantage of doing it in a patient a real patient, not just a mannequin. So you're getting real life experience. And essentially what it is to put the patient asleep and then put a nasal trumpet into one nostril, and then put when the patient's off to sleep and paralyzed, and then jet ventilate into the lumen of the nasal trumpet, which then oxygenates and ventilates the patient. And then the resident now, in a patient who's asleep and paralyzed, well oxygenated and safe from all standpoints, the resident's able to do the fiber optic intubation under control conditions without the concerns of what I mentioned, and can focus on perfecting the skills. And Tim Ness helped me get this organized as a presentation, and we published this as a way to educate residents to learn fiber optic intubation. So yeah, I really think that has been a major contribution. Hasn't quite caught on the way I thought it would, but you know, a lot of these things, they take time, and but it's one that really works. And it was the cooperation of the OMF surgeons, Peter Waite and Patrick Lewis, who were really supportive in doing this for their patients, because it's a safe way for the patients to be intubated with these nasal tubes.
As a resident who's benefited from this learning technique, it also improves the glottic exposure with the jet ventilation as well. So it's
well, that was a gift. That was something that I didn't expect, but what happens, and about 75% of the time, when the jet is deployed into the lumen of the nasal trumpet, the glottic tissues just open up, and you get a better view of where you need to go. So it does facilitate the process.
along the lines of your airway innovations. The poor man's LMA is very well known here at UAB. Can you speak to its creation, Dr. Boyce?
Yeah, it's kind of a goofy name, and actually one of our former faculty told me that we should drop it, and I tried to drop it and get a better name, but nothing else fit. But the poor man's LMA does, and all it is taking an endotracheal tube and sticking it into the oral pharynx around behind the tongue like you would an oral airway, and then sealing the lips around the tube and pinching off the nose and letting somebody hook up to either the circle or an ambu bag. You can ventilate a patient. And there's the French factors, as I call them. These were predictors of difficult mask ventilation that came from France. The author was Langeron in the year 2000. First publication ever, by the way, predictors of difficult ventilation. Everything else, every other publication dealt with difficulty with laryngoscopy and intubation. But this one, difficulties, predictors, difficult mask ventilation, Well, patients with a beard, edentulous, overage and obese, and these were factors that it's hard to get a mask fit. Well, the poor man's LMA solves them all. It's not a problem. And we found that patients with a lot of facial hair or morbidly obese, they're very easy to ventilate using this technique. But Sergio Gregoretti, he said, you know, you got, in his Italian accent, he said, you got to get rid of this name, poor man's LMA. It's not academic. I said, well, Sergio, it's what it is. That's what people know.
When did you start using the poor man's LMA? And how'd that come to you?
You know, I don't know. I don't know how the idea came, but you know, sticking an LMA in can be a little cumbersome. Some mouths are small and it's not simple. But I thought it was a great idea. But I thought, you know, it just seemed obvious that, well, just stick a tube in and blow up the cuff and you got next to an LMA, and it's a lot cheaper at that time. Now, LMAs at that time were about $200 and $250 a piece. And so compared to a $10 endotracheal tube, well, if you're a poor man, you use this.
Another thing UAB is privileged to that's not widely known is your Boyce tables. Can you tell us how you came up with your Boyce tables, another obvious problem that you solved?
Well, yeah, it always was interesting to me why, for as long as I had done anesthesia and everything that I saw, the anesthesiologist would put the endotracheal tube on the patient's belly and for the induction, and several times it would fall off on the floor. So it seemed clear that, you know, if we had a table that was, and the first one I designed, which I got a patent for, by the way, attached to the side rail of the OR table. And that, you know, so that would solve the problem. You could put all your instruments on this table and it wouldn't fall on the floor anymore. Well, the second step of that was the table that clamps to an IV pole. And that's actually better because it rolls around and you know, it's more use for A-lines and for CVPs as well as intubation. Now the way it got started was, I had this idea in my mind for a number of years to solve the problem I described. Well, when I had a faith change in 1987, at this time I had left Elba and was in Birmingham. I needed to go back to Elba to tell some people about this. And one of the people I talked to was my neighbor, Ed Tucker. Now, Ed Tucker was a brilliant man, not educated, but he was brilliant. He would design things and design things for Dorsey Trailers, which was a trailer manufacturer in Elba at the time, and at Fort Rooker. He was very gifted at creating ideas and kind of a mechanical engineer without a certificate. Anyway, when I went to Ed's house to talk about this faith change that I had, the conversation ended, and I was kind of left with nothing more to say. So I changed the subject and said, Ed, by the way, I've had this idea, and I described the idea of the table. And he listened, he took a napkin, and he drew the picture on a napkin. And he says, is this what you're talking? I said, yeah, that's pretty much it. He says, well, sign this. Sign the napkin? He says, yeah. So I signed the napkin. He sent that in, and that's how we got our patent pending status on the Boyce table, the first one. And now we started to grow and enhance it, and et cetera, and we had we had a company formed, Boyce Medical, and I hired two actually reps who were working for other companies came to me, and they wanted to market these because they thought they'd really go. Well, we had sales in the Southeast, maybe in 7 states, and but I never could get the critical mass to make it really go on its own. And what I ended up doing was losing about $200,000 in the in the process. But you know, you have to try. But there are still a lot of them around, and I gave a bunch to our department. So there's, if you ask for a Boyce table, that's what they'll bring.
The next topic I'd like to hit on is the topic of the non-depolarizing muscle relaxants versus acetylcholine,
Yeah.
which is a fun topic within our department because of you. I wonder if you could talk about your time as the chief of the anesthesia services and how that led you to sort of formulate your opinions on.
Yeah.
On that.
Well, I had that job for 8 years, and it is a grueling job because every day you come with the concerns and the responsibilities of keeping everything running, keeping all the ORs going with all the people and having enough people to cover the rooms, and it was just a constant attack, and you know, a lot of times it was friendly, but it was still an arduous time. Well, in that position, I remember for the first 2 or 3 times getting a call, please go to OR 14 or 16, emergent. And so I'd run down, and what had happened in each of these cases was the patient was put to sleep, a morbidly obese patient, and succinylcholine had been used along with the hypnotic, which at that time would be pentothal. And they were able to mask the patient, oxygenate the patient fairly well, try a laryngoscopy and intubation, which failed. So the patient, being morbidly obese, desaturates quickly. So they come out and they put an airway in and mask the patient, bag the patient, bring the oxygen levels back up, and change the blade, change positions and things, and try again. And this time another failure. Have desaturate very quickly, and then come out and bag and try again. And this time the saturations are slower in coming back up to full value of near 100%. And you call for help. They called for help. Somebody would come and assist and use their blade of choice, etc. Maybe use a bougie. Again, another failure. And this time, when they come out with the desaturation, they try to mask ventilate, and they can't. And they can't because the patient has recovered in the period of time from the succinylcholine. And what's happened is, with all the attempts at the supraglottic tissues, there's enough inflammation to cause the glottic closure reflex to now be fully active, and you get glottic closure, and now you can't intubate and you can't ventilate, and it's crisis management. And then when I arrived after the 3rd or 4th time, called for a similar story. That was the surprising thing, how common this thing was, this event, that I would first grab my kit to do the cricothyrotomy before I even went to the OR, and I'd be ready to do the cricothyrotomy and jet oxygen into the patient. Now, sometimes they would recover enough to be able to be ventilated without the cricothyrotomy. But it was clear to me that, you know, the culprit here is the short action of duration of action of succinylcholine. That's wearing off, and now you've lost the advantages. So if, and it's a huge if you are going to put the patient asleep and use a muscle relaxant, then give one that gives you a big, wide window of opportunity so that you can always go back and maintain oxygenation with ventilation. And I would say, and this is no exaggeration, but my very best friend here is Art Boudreau. No question about it. But he is one with whom I have the most and the clearest disagreements with. And he's a succinylcholine man, and I'm a rocuronium or man in this regard. And we'll never come to an agreement on it, but he's still my best friend.
What other lessons do you think you learned in that position, being the chief of the
services? Learning how to control my Irish temper. You know, I guess this goes back to hockey days. You know, if something goes that's not to your liking, you get that buildup of anger, and you know, you're going to retaliate in some way, and you're going to, well, you know, it's goofy and it's crazy and it doesn't solve any problems. It just creates more. So learning to control that and say, you know, that is, I don't always have to be right. In fact, I remember a classic exchange with Loring Rue, who's still here at UAB. And when he was doing his, he was a young surgeon here, and I was floor running. I was chief of anesthesia services division. And we had some major disagreement on something, and we're outside just in front of on the 7th floor there in Jefferson Tower, just in front of the nurses' station. And he just looked at me in the eye, and he just came up to me and says, "The problem with you, Boyce, you've always got to be right." And I thought, geez, you know, there's wisdom in that. That's because you're not, you know, and just to kind of dig in and hold your position irrespective of the circumstances is crazy. So anyway, learning diplomacy, learning that there's always a better way, validating people and their efforts, being an encourager, not a critic. Look, some people need to have some of their habits changed, but yeah, even that can be done in a way that's not punitive or pejorative. It's looking to bring them up, not identify it to hammer them down. That's, I think, the important qualities and what I tried to learn. And there were lots of people who were I could learn by example in that regard. Ed Ernst was very good at that. Hamdi was too, Hamdi Erdemir. And they were very helpful.
Can you mention some of the other positions you held while at UAB?
You know, that's been one of the joys of being here, is the opportunities at UAB that you can explore. The first one I had was Director of Resident Education. That was a great job. And you have good people, and you have to have good people. Cindy Pukta and Patsy Bird were the two that were extremely helpful to me and keeping things running, you know. But that was a fun job, and so I did that for a season. And then I was the Associate Dean for Student Affairs. It's fun because now there's faculty here in GYN and surgery, like Sam Wyndham. I wrote his dean's letter, and you know, I see these guys, and you know, I'm still talking to them, and it's kind of a different relationship, of course. But one of them I says, look, you know, if you don't, you know, sharpen up here in this regard, I'm going to have to rescind your dean's letter and rewrite it. So, but that was a fun position. And then when David Chestnut came as chair here, I assumed the director, division chief, and that was an 8-year position. And then prior to the arrival of Dr. Tony Jones, our current chair, I was the interim chair for, I guess, just over a year. And that was that was fun. That's where you really value the support people around you. At least I remember as being that one of the essential things, because there was so much about it that I didn't know anything. Finances, I didn't know squat about finances of the department, but we had Don Bulgarella then, and of course Cindy Lauterbach and Sue Berger were extremely helpful. So they just make it happen, you know, when you've got that excellent support system. So, and now I'm one of the truck loaders, and that's fun too. I like the role. I like doing what I'm doing. But I think that opportunity to, you know, to experience these other things that's what makes it fun.
Can you talk about, I mean, every other year you're probably voted Resident Teacher of the Year. Can you talk about education a little bit? What it means to you?
Well, I think the best way to sum it up is I really, really love doing it. As I mentioned, you know, going through school, I had to really work hard to accomplish, to make the grades. I remember going through, even in public school, I used to get my report card, always had a note in it saying, Jim does not seem to understand what he reads and therefore has been put in a special reading class. I hated reading. And, you know, I think a lot of it was maybe, I don't know if there was a name for it, I don't really care, but I knew that there was a challenge there, that it didn't come easy for me. And even now, to read something, I have to go off somewhere, be quiet, and really work at it to understand it. And consequently, it really forced me to learn ways to simplify what has been presented and what has been written, and for my own understanding first. And then once I've got that simplified understanding of the topic, the fun it is to present it, because it's easy once you've got it together and you've got a handle on it. I think the best example would be the topic of pharmacokinetics, which if you read a textbook on pharmacokinetics, I mean, I get lost. I understand pharmacokinetics, but I get lost trying to figure out what they're talking about in terms of the equations. It's like it's made more complicated than it needs to be. But I can present an hour's talk on pharmacokinetics that I know is accurate, I know is clear, and it's fun. And it kind of demystifies a lot of it, and you know, here's something practical that you can take away from this. So I think having to work at understanding things has been an advantage for me, because once I work hard at getting something together, it's a lot of fun to teach it and to convey.
You lecture a lot within the department as well. Can you mention some of your favorite topics to lecture on?
Well, of course, the lecture that I've given the most often is management of the difficult airway. And I was adding up the other day, in the near 29 years that I've been here, I think I've given that talk 350 some odd times. So I know the topic, at least that talk, I know it pretty well. So that's a favorite. But I also like lecturing on basic things, like the basic understanding of inhalational agents, basic understanding of muscle relaxants, basic understanding of and a paradigm as to how to manage a patient with a history of severe bronchospasm, asthma. I enjoy those because one thing is you get a system organized, and then presenting it is fun. I am a bit of a ham, I know that. My mother was, and she would present things. She was an elocutionist which are almost unheard of these days, but she would recite poems for public presentation. And to get up on stage and do something, I like to do that. Now, some people don't, but I enjoy doing that. And to make it interesting, make it clear and entertaining, but educational as well, is fun.
You spent a lot of time as an ABA examiner as well. Can you talk about your experience with that and why you eventually ended?
Yeah. Bill Owens, who was featured in this issue of Anesthesiology, was my mentor when I first started this, and getting involved in it was in the encouragement of Ed Ernst when he was the chair here. And so I didn't know a lot about it, but it was clear that I might succeed at it, and so I signed up and joined in and participated in the training program. It was a good experience. It was very. It's not easy. It's not like a relaxing week away. You work really, really hard, trying to think of another question, trying to listen to what is being said, and grade what was previously said, all at the same time, is a major challenge. And you're exhausted. You're mentally exhausted at the end of the week. But I enjoyed it, and I'm thankful to Bill Owens. He was very kind to me, encouraging me in those early times when you're really worried about how well you're doing, which is an interesting thing because as a candidate goes to be examined for the boards, for their certificate, what they need to realize is that some of the examiners they're going to face are probably more concerned about how they sound versus what kind of answer is being presented. But it's a good process. It's not foolproof, and I'm sure we fail some that shouldn't fail and pass some that shouldn't pass. But you have to have something in place, and that works fairly well.
The looking back just over your career at UAB, what has been some of your highlights you feel like, and some of your challenges over the years?
Well, I would think in terms of highlights, having experience with the different positions would be top of the list. Having, being active and seeing how other areas of this institution function and being a part of it, being a participant, that's been really, I think, the most valuable. And of course, being involved with students and residents. There's always a new batch coming through, and they're all different personalities, and that's wonderful. That's a lot of fun. So I think the people interaction would be the major factor in those things.
Speaking of those people, have you found in particular anybody that's influenced you a lot in how you ended up practicing anesthesiology within UAB? Have you had any mentors as you've gone through?
Well, there have been. Of course, I mentioned Hamdi Erdemir. He was an incredibly skilled blocker. He probably set up the first pain clinic in the state of Alabama, and he could block anything. He was just very, very skilled. So that was a major encouragement to me. I think learning the administrative skills of Ed Ernst and watching him function, even with very, very difficult situations, was a real value. And the colleagues too. Like I mentioned, Art is Art Boudreau, a very incredibly skilled anesthesiologist with the techniques he uses, and learning from him and others that have skills that you can look at and say, that's something I'd like to get really good at. And So there's lots that have come through, and I've been associated with through the years. One of the disappointments is that some of them that I feel would be excellent as teachers, maturing and really, you know, contributing well and having a lot of fun to do it. They get lured off to private practice, and I'm not saying anything wrong with private practice, but when you see somebody who would say that would be a great teacher, that person, you'd like to see them stick with it. Now we're getting one come back, and that often happens. People who go out for a season, and then, you know, they've probably got the teaching gene, so they have to exercise it somewhere, and so they come back. And like Jeremy Smith is coming back, and I'm thrilled about that because he's a smart cookie and great guy, and he'll be an excellent addition to our department.
What are some of the most significant changes in our field that you've seen?
Oh yeah, well the major one is the pulse oximeter. You know, I probably used the first pulse oximeter. It was an old Marquette in University Hospital, and it was in the ENT room, and we were using it on kids. And when we saw how quickly they desaturate, and we had never known this because, you know, this is long before color change, before cyanosis. But my goodness, I thought, we have been doing this for years and years, and we didn't even know it. And now, of course, it's a standard. That is, unless there's extreme circumstances that have to be explained, you have to have a pulse oximeter in place. So that I think is the most significant. And then, I very closely coupled to that is the ability to measure end-tidal CO2. It was Barry Shaw that brought to my attention that this is the proof of the pudding with regards to, is the tube in the right place. And, you know, I thought, yeah, it's probably okay, and I didn't think much about it. But Barry was the one, you know, when it first came into common use, he was saying, look, this has got to be in every room. This is just the only way you can really know if you're in the trachea or not. So those two things, the pulse oximeter and the end-tidal CO2 monitor, I would think would be the most significant advances, and I think they have improved our you know, our numbers more than anything.
I mean, I can't imagine all the changes that you've bared witness to just within UAB health system. Can you talk about some of those?
Well, I can illustrate it with a story that happened to me when I was a resident. This is how monitoring what we do today versus what was done when I was training. I can remember as a resident, we had a patient, and I was concerned about the blood pressure. And, you know, of course, it was just the sphygmomanometer that you had to blow up by hand, and I'm there pumping away, blowing up this, and my faculty, my staff man comes in, and he says, "What, Boyce, what are you doing?" I said, "Well, I'm concerned about the blood pressure." "Oh, you don't like the blood pressure?" "Well, we can fix that." So he reaches over, takes the cuff off, and throws it in the corner. "Now," he says, "just put your finger on the pulse. That's all you need." Well, that's all we had. I mean, to monitor the EKG, oh my goodness, that's just absolutely off the wall. I mean, that's crazy. You don't need to do that. But that's that was the attitude then. It was strictly clinical. Now, of course, it's standard and good thing too. I think it has made the practice a lot safer.
Do you feel like your Canadian background changed your experience coming to Alabama, coming to UAB at all?
Well, it did. The Canadian system is much more socially geared. In terms of right and left, it would be more left. That is the practice that is set up as a provincially run insurance. That's what it is. The insurance plan is provincially run, so that's what controls numbers of cases, operating rooms available. The whole thing is controlled by that. And I'm sure some would argue that there are some good things about it, but I think if you look back at the way medicine was in Canada prior to this and the way it is now, I think that we've lost ground, and the waiting lists. My own mother, for instance, had to wait a long time to be investigated for a lymphoma, and they thought it was her gallbladder, which was a reasonable diagnosis, but to be on a waiting list that was going to take 6 months, well, as it turned out, she had lymphoma. She didn't have she had gallstones, but that was not her problem. That's the adverse outcomes of some of the social aspects of healthcare delivery. So when I came south, it was like I've improved. I've come into a system that has more advantages. And we seem to be sliding into what Canada has gone through in the recent past. So I think my experience in Canada has given me an awareness of things we really need to be on the lookout for. But there's one area that I want to comment on, and it has to do with just the presence of a third-party payer, whether it be a social system that is government or state-controlled, or if it's private, it's still third-party. And I believe strongly that we as doctors have lost a lot with the presence of a third-party payer. I'm probably the only one left in this institution that had the advantage of, prior to the arrival of a provincial healthcare system in Canada, but I had the opportunity to practice where I knew that the bill I submitted to that patient was going to come out of that patient's pocket. That if I ordered a test, that patient was going to have to pay for that test. Now, with a third-party payer, we don't think about that. We just write, in fact, they're packaged as BMP or whatever it is, that just a whole bucket full of things, and you don't even think about the fact that this is costing somebody. And the other thing that we've lost is the best medicine that you'll ever practice is that where you know that that patient is going to pay out of his pocket. It's a contractual, it's part of the business, which is not a bad thing. It's part of the business aspect of the practice of medicine. And I think we lost that relationship between doctor and patient at the business level when we have a third-party payer. And I think that's to the detriment of our practice. Now, how you're paid is interesting, because I can remember when I was a GP in Prince George, a patient came in and he said, you know, Doc, my kids need their tonsils out, and I'd like you to do that in the summer if you would. And I said, okay, that'd be fine. I used to, as a GP, I used to do some surgery, and tonsillectomies and adenoidectomies and things were part of it. So he says, well, now I'm a farmer and I won't have any cash. We talked about the cost. He says, I won't have any cash in the summer, but in the fall I'll be butchering. How about a side of beef for your fee? And I said, oh, I think that's wonderful, yeah. So I took his kids' tonsils out in the summer, and that fall, I've forgotten how long it was, but a drive up to the house comes this packaged meat that he had butchered and packaged for me and put it in the freezer. So, I mean, that to me is a wonderful experience that, you know, it's, of course, you can't do that all the time, but it was fun.
Looking forward, what challenges does anesthesiology face in the future?
Well, I think the major challenge is to not to get too overwhelmed with the social changes in healthcare delivery. If we do, and that starts to consume us, we'll be shifting our focus from where it should be, and it should be on the patient. You know, no matter what the system, and I'm not saying we should ignore, not fight, or not contest, or whatever, but it shouldn't overwhelm us so that we lose sight of the fact that our care of the patient is the primary focus that we should have. And I think that's the challenge. You know, no matter how that patient got to be here or whatever, still the patient is injured or afflicted, and they need our care, however we can provide it.
Looking back over your entire career, this will be my last question, what do you feel you're most proud of?
Well, I think the thing I'm most proud of is that I'm married to the bride of my youth from the high school graduate from Elba that I met in Georgia. That relationship has been, you know, it's a lot of twists and turns like all relationships, and we've come through some trying times, but I think that which we both enjoy now and have over the years. We had our 45th anniversary last May. That's the one I would hold on to with on earthly values as to what is most valuable, and of course the three children are close to that. So that's family and the marriage, and then professionally it would be I'm very thankful that I've had opportunities to do different things, including be a GP for 10 years in total. I loved it. Loved being a GP in the South, in Elba, this little town. Incredible, these people, you know, they're very, many of them are very, very smart people, not necessarily educated, but they're smart, they're savvy, you know, and getting to know them and getting to know the customs. Of course, as a Canadian coming to Elba, Alabama, I had to learn the language, and I had to learn what swimming in the head meant and running off at the barrels, and, you know, different phrases that I'd look at, or falling out. That was one of my favorite. Doc, I just fell out. What do you mean you fell out, or what fell out, or what are you talking about? Well, I don't know, Doc. He says, I just was going along and on the tractor and I just fell out. Well, I had to get some people in to help me understand that. And the sense of humor. The sense of humor was fabulous. Let me tell you just one quick one here. This is a man that I saw in the emergency department. And what had happened, he was out doing some logging and a branch fell off a tree, hit him in the head, and he wasn't knocked out, but he was hurt. So he went to the chiropractor. And the chiropractor took an x-ray, things looked fine, and he gave him an adjustment and sent him on his way. Well, the patient, 2 weeks later, comes to the emergency department, and I'm there and check him over, and I asked, and he says, it's my neck. He says, it's just gotten terribly painful and something's wrong. So we took an x-ray, and he had a small fracture of the transverse process. And so I told him this. I said, now this is still stable, you're okay, but it is a fracture, and that's why you're having the pain. And we'll put you to bed here and put you in a neck collar and fix you up, give you something for pain, and it should eventually be okay. So I went to see him the next morning, and he started telling me the situation and what had happened over the previous 2 weeks. Now he says, "No, Doc," he says, and this is long. I mean, he draws this out for about 15 minutes, you know, this little monologue. "Doc," he says, I need to tell you that I got a problem with this, what's happened." He says, "You know, I got hit in the head and I went to the chiropractor. And he took an x-ray and there was no fracture. And then he gives me this manipulation. And now I have to come back to the hospital 2 weeks later, and my neck is sore, and you take an x-ray, and now I got a fracture. Now, I got a bill from the chiropractor. And best way I can figure is, this chiropractor wants me to pay him for breaking my neck." Well, you know, that's the humor of South Alabama. But I loved it. I love being there.
One more question, or a couple more. What are important characteristics for an anesthesiologist to have?
Number one, I think to be a good anesthesiologist, you have to be a good doctor. And you have to think like a doctor, and that is, I think I outlined this before, that you can evaluate, you can do it quickly, focus in on what's important, and do that efficiently and quickly. I think along with that are being skilled and honing the skills, and think about ways to improve the skill. Just like how you hold the laryngoscope, or how you position the patient's head and body on the table, and how you would bring it up to a level that's advantageous for you. And then thinking in terms of working with the colleagues. That's one of the beautiful parts of our job is it's a very sociable profession, where you're interacting with so many people, nurses and surgeons and colleagues and students, and there's lots going on in the operating room, and developing an understanding that they all here have purposes, and nobody's purpose is of any more value than anybody else's, because without even one of them, it wouldn't work. You got to have all the pieces. Even the guy that comes in and cleans the floor, he's got a purpose, and that's important. And I think valuing people and all that they do for patients is part of it as well. And then being a lifelong learner. There's a phrase from William Osler that I think is so appropriate. I think I've got it right when I say, "It is surprising that with such little study one may practice medicine. What is not surprising is how badly they may do it." So I think being a lifelong learner, being keen, being aggressive to want to learn, to get, like the pillars I was talking about, go deep into something, and then have a desire to teach it, I think is just sort of, it's just more of the enjoyment that you can have at it.
And how would you want for people to remember you at UAB?
Well, I like the idea that I'm considered good at what I do. That's probably lots of hubris with it, but you know, I'm human, and yeah, I like being well thought of. I like the idea that people know who I am as a man of faith. I'm Christian, and I don't want to, ram it down anybody's throat, but I want it to be evident in how I do things, or what I say, or how I behave. That's important to me. And then as just as a good citizen in the community at UAB, with different people, that to me is very important.
Well, Dr. Boyce, thank you for your time today, and I think more importantly, thank you for your service at UAB for the past 28 years. So thank you.